Good evening, student. Today, this ideal critical care course topic is neuro critical care and what is new in the acute subarachnoid hemorrhage. And we have the eminent faculty, Dr. Sourav Burman. He has done DNB, IDCCM, DM in neuroanesthesia and critical care from AIMS Delhi. Right now, he is a associate professor in Kulani AIMS Medical College, and he has a vast experience on the neurocritical care because I know he has worked neurocritical care for quite a long time in Institute of Neuroscience in Calcutta, and after that right now he also in AIMS is doing the anesthesia and the critical care, and the basically is focus on the neurocritical care.
Good evening, everyone, and thank you to Dr. Asif for giving me this opportunity. So, without wasting much time, because this is a very interesting and a controversial topic, so I'll start my presentation. I'll be discussing on the aneurysmal subarachnoid hemorrhage. So, what is new in the management of aneurysmal subarachnoid hemorrhage, which will be mostly in the contemporary management of aneurysmal subarachnoid hemorrhage from the intensivist point of view. So it will be more of critical care than the anesthesia part. So I will be taking references of a lot of articles which have been taken recently in critical care. And the most recently, this 2024, this article is a landmark article by Chara Roba, who is considered to be the father of neurointensivist part in our in Western world. So it is a contemporary management. So we'll be discussing the ICU related topics, not the pathogenesis, pathophysiology, and the diagnosis or how to do. So when do you require an admission of such a patient? So when a patient comes to you with a subarachnoid hemorrhage, when and how long? These are the two questions that you should ask. So obviously, there are several scores in subarachnoid hemorrhage, starting from the modified Hunt and Hess score, the World Federation of Neurosurgeons score. Then there is the vasograde scale. Then there is the modified Fisher grade, which is done and the CT scan. So all these scores are done with one purpose to identify the at-risk patient. Now, what do you mean by at-risk patient? Is those patients who are having a poor grade aneurysm or a good grade aneurysm. So a poor grade aneurysm patient need more ICU admission. They are needs to be intensively managed. So in all the scales, whether it is a modified Hunt or WFNS, the poor grade scale generally a Hunt and has more than 3, or WFNS also on the higher side. The Fishers, which is 2 and above, that is thick SAH with IVH present. So in all these things, you require an ICU admission. And for how long, it is also a bone of contention. There are several studies, whether it depends on the type of the bleed, the nature of the aneurysm, whether the aneurysm has been secured early or late, and the associated complications. So before securing any aneurysm, when a patient comes to the ICU, it is early management. This is basically theory. I will not spend much time. ABC, airway breathing circulation, neuroimaging, CT angiography, DSA, digital subtraction angiography. For the students, the gold standard is still the DSA. And then the drug that has been age old, it is confirmed by the British nimodipine trial, the nimodipine which has got a mortality benefit in this aneurysmal bleeds, and a new drug, or rather an upcoming drug, which is milrinone. So, when a patient comes with an aneurysmal bleed, the first complication that strikes our mind is whether it is a chances of rebleed is very high. Now, chances of rebleed has got a poor outcome. That is 6% risk of mortality in the first 24 hours, and if next 48 hours, another 6% then lead to higher chances of mortality. So recommended to secure the aneurysm within 24 to 48 hours. Now there is debatable. There are two school of thoughts. Now what is early securing of aneurysm? Within 48 to 72 hours, and late is after 72 hours. So before I go to the next point, I would like all of you to concentrate on this original contribution by the stroke, which is a very big landmark trial. That is the timing of the aneurysm treatment, whether you go ahead with an early or a late. So this is the relationship with delayed cerebral ischemia. So there has been a temporal relationship between delay in treatment and risk of delayed cerebral ischemia. So the worst outcome, it is seen that after 10 days of the ictus is the day of first bleed. So postponing or securing the aneurysm from day 5 to day 10 or delaying it is not recommended. So now whatever is followed, if it is an aneurysm, there is a risk of bleed and it has been proven a ruptured aneurysm, it is better to secure it. So next comes the role of tranexamic acid. Now, again, it was first thought that tranexamic acid is an antifibrotic agent which can help in preventing further bleed, or it can reduce the chances of further bleed. So, few trials have come up, but the noteworthy trial here is this Lancet trial, which came up in 2021, which is the ultra trial, ultra early tranexamic acid. So how early? So they gave it within 6 hours. Now this trial was done in US, UK when the patient arrives to you within 6 hours, but in mostly in our country, mostly the patient will not arrive in such fast. So there they did 1 gram bolus, and then it was followed by 1 gram per infusion, 8 hourly infusion. So the rebleeding incidence was seen less in the tranexamic group, but unfortunately there was no mortality benefit and there was no effect on outcome at 6 months. So it fell out of favor because most of the time the patient comes out of the window of 6 hours. So role of tranexamic acid is now still controversial. Control of hypertension, yes, again, a very recently I gave a talk on BP targets in different types of stroke. Well, this is also a very important thing, that control of hypertension, BP less than this number, that number is not there. That is a tailor-made therapy for each patient, which I will come later. So the next important complication is the hydrocephalus. The hydrocephalus is a very commonly seen in patients with intraventricular hemorrhage, the third and the fourth ventricle. It presents with obviously signs, Cushing sign. All these are Cushing signs. Mechanism is obstructive versus malabsorptive, and treatment is varies. Now, if it comes with ballooning of the ventricles with a severe hydrocephalus, you have to go ahead with the CSF diversion procedure. But here, two things you have to taken care of. First is the raised ICP versus a CSF diversion procedure. So, EVD is the safe technique rather than a LP or a lumbar drain. But very recently, rather in August 2023, we have come up with this JAMA article, which is the basically early drain trial. It has found out the effectiveness of lumbar CSF drain among patients with aneurysmal subarachnoid hemorrhage. So what they did there, the lumbar drain, as soon as the CT confirmed it to be subarachnoid hemorrhage, the lumbar drain was inserted with a median of 2 days. So what they found is that there was less incidence of secondary infarct in the lumbar drain group. and there was a propensity towards better outcome in the lumbar drain group. But how, what is the better outcome is there was no mortality benefit, but there was increase in the modified ranking score of upper level and lower level disability at 6 months. So again, there is no mortality benefit here. So mind it, when we are thinking of poor grade aneurysms, again, we have to be very careful that there is not further mortality benefit. But if it is a intermediate grade aneurysm, there can be improved probability of upper limb disability. So now, after this, the next important thing that needs to be discussed is the treatment. So, briefly, because most of the time the patient comes to you after this treatment has already been done in the ICU, whether the aneurysm has been clipped or coiled. And obviously, there was this ISAT trial which had said that there was a timely repair reduces the risk of rebleed. I have already cleared the controversy of early versus late, and it is always better choice. It depends on the type of aneurysm, the anatomy, the dome to neck ratio, and obviously the clinical grade of the patient. And fifth thing is the blood in the ventricles. So now coming to the anatomy, whether it is an anterior circulation versus posterior circulation. Very recently, we have come across this Swede et al., this neurosurgery trial, which they have compiled the data from International Unruptured Aneurysm Registry, that is the IUAIA. So, a better outcome was observed in anterior circulation aneurysms and in recurrent bleeds, where they went for clipping, and they found that clipping is better. So if you see here, yes, my pointer is here. Predictors of recurrence is young age, hypertension, rupture aneurysms, large aneurysm size, and treatment via simple coiling. In the setting of recurrence, microsurgical reconstruction could lead to improved outcome in terms of dural abdomen compared to simple coiling. So in this case, they had said that it is clipping be the best treatment in such cases. But still, ISAT and other trials, they have shown that in posterior circulation aneurysms like basilar top, it is coiling which is better because of anatomical difficulty in reaching those areas. And second thing is that in both the scenarios, coiling reduces three things. One is length of stay, intraoperative morbidity, and third thing is the risk of secondary infarcts. So it is still a debatable topic. So again, further trials are warranted, but as of now, there is no clear guideline which is suitable for each scenarios. Coming to the management. So after the aneurysm is secured, optimization of vital parameters, and obviously prevent and treatment of secondary complications. We have already discussed rebleed, we have already discussed hydrocephalus. BP target. So BP target. So sorry if this slide is not showing properly, but if you can see that uh, there are three guidelines that I have shown you. Neurocritical Care Society guidelines in 2011, Stroke AHA ASA guideline, and there is guidelines of the Neurocritical Society again in 2023. So you see that in earlier phases, that extreme hypertension prior to obviously securing the aneurysm must be treated. So it has to be less than 110, or SBP MAP or SBP has to be less than 160. And premorbid baseline blood pressure should be used to refine targets. But when it came in 2012 by the ASA, what they said is that to reduce the risk of rebleeding, the exact magnitude of the BP control was not established, but a decrease to less than 160 is okay. So it should be controlled by a titrable agent, balance the risk of hypertension, related rebleeding, and obviously at the same time, we have to maintain CPP, cerebral perfusion. And finally, in the 2023, what they have said that there is insufficient evidence recommend a BP reduction goal for the treatment of hypertension before aneurysm securing. So again, it is a tailor-made therapy. Now you cannot say it should be less than 160, it should be less than 220, it should be less than 110. So in patients with aneurysmal SAH and unsecured aneurysm, frequent BP monitoring and BP control with short-term, short-acting medication is recommended. What they are nowadays saying that it is always better to keep it within 20 to 30% of the baseline blood pressure of the patient. So there is not a particular number. So everything has to be guided according to frequent BP monitoring and the baseline blood pressure of the patient. Sedation, obviously, these patients will need sedation. So minimize, avoid shorten ventilatory period. So length of hospital stay, monitoring, all these things usually required. Why sedation is required? Because we wanted a calm and sedate patient, decreased pain, agitation, and respiratory failure. So choice is varies from propofol, midazolam, ketamine. Analogous sedation with dexmedetomidine is coming up. Short studies or short pilot studies have already happened, and it is useful drug. It has minimal effect on CPP, and it causes central sympatholytic also. And the only concern that happens is that there is increased chance of bradycardia with dexmedetomidine, but its effects are negligible. Specifically, only in cases of very much raised ICP, it may be contraindicated. Even ketodex, that is the synergistic equiosmolar combination of ketamine and dexmedetomidine, has been advocated in a few case series. So, rebleeding, as you can see, I have already told you, maintain hemodynamic stability, avoid the peaks. Not recommended antifibrillary agent, as it is, I have told you, the ultra trial failed to show any mortality benefit. Hydrocephalus, consider CSF drainage, consider risk of intraventricular lysis. And third is intracranial hypertension, consider ICP monitoring. Now, this again, our trial has come up, and there is a big study also I'll be discussing later. DCI, which is the most dreaded complication after a management in the management of SAH. So it has to be a clinical assessment. Now, by definition, DCI is clinical diagnosis. It is fall in GCS by 2 points or new onset neurological deficit. So CT angiography or anything must be done to rule out, but the best handy tool that you can have here is a transcranial Doppler. Though there is one saying that the patient can have a vasospasm, but he may not have DCI and vice versa. The patient may not have any vasospasm, but still he can have a delayed cerebral ischemia. So DCI is not just vasospasm. It's make it very clear. So DCI is a clinical diagnosis and vasospasm is an angiographic diagnosis. Seizure, no indication for prophylactic treatment. Start anti-epileptic therapy in case there is seizures, but there is no role of prophylaxis. Serial EEGs to detect and titrate the therapy, and consider continuous EEG, of course. So now coming to each of these complications, first I'll go to DCI. 30% risk. It generally sets in after the vasospasm or during the vasospasm period. It leads to functional disability. 50% with angiographic vasospasm, non-angiographic vasospasm, it can also come. So I told you there might be vasospasm or there might not be vasospasm, but there DCI can happen anytime. So next, multiple factors. So what we can do is that we can reduce the risk. Hello, hello. Somebody is speaking, and is there any question?
Susmita, please mute everyone.
Sorry, I'll continue. So first we had enteral nimodipine, which was told us by the British nimodipine trial, and now we have intravenous nimodipine. The enteral nimodipine was 60 mg every 4 hourly. Now we have enteral nimodipine, IV nimodipine, which is 1 to 3 mg per hour is the dose. Clazosentan, again, it was a trial, which is, I'll come to the next page. If you can see my pointer, this is the clazosentan trial, the conscious trial, CONSA, conscious trial. Why clazosentan is obviously an anti-inflammatory action. It has got anti-inflammatory immunomodulating action. So they used it. The clazosentan trial was in IV dose of 10 mg per hour. So they believe that it will reduce the vasospasm related morbidity, but the all cause morbidity and as well as the all cause mortality within 6 weeks, including new cerebral infarcts, was not being modified by clazosentan. So clazosentan reduced vasospasm, angiographic vasospasm, but it had no effect on new onset cerebral infarct or all cause mortality. So this also went out of favor, clazosentan. Similarly, nimodipine, obviously the drug of choice till now. We can use it oral, IV. Newer ways, you can instill it by any device. It can be given through an Umaya reservoir in the brain. It can be given through the EVD. It can be used intraarterial, as well as two trials have come up which have used nimodipine along with balloon angioplasty combination therapy. So proven the preventive strategies are limited. So this I have discussed. So next coming to the DCI, how do you diagnose it? So gold standard in case of vasospasm is DSA. TCD, obviously you can daily perform it. It is a very handy tool. Continuous EEG. Now I have already told DCI is a clinical diagnosis. It can present with non-convulsive status also. So a continuous EEG in combination with TCD gives you the best scenario. And obviously, if you have invasive monitoring, you can have a PbTO2. What is PbTO2? It is the brain oxygenation, invasive cerebral oxygenation. So all these things can be considered. So no data supports treating subclinical vasospasm. Treating PCI, how to treat that? Improve perfusion or prevent infarction. So now this thing that has come up is induced hypertension. In the absence of heart failure, optimal target is unclear, but it is still controversial. Why? I'll tell you. Because of this. This is the largest trial that was taken, which actually compared induced hypertension versus no induced hypertension. This is the Himalaya trial, which came up in the year 2013. But unfortunately, this trial was halted because of slow enrollment, but the interim analysis that is had no clear mortality benefit. So they induced hypertension. How much hypertension? It was 30% above the baseline of the patient. And the map was 120 to 130. No ideal vasopressor. So they used phenylephrine in certain cases. But what they found out is that it did not have any mortality benefit in the interim analysis only. So this trial was stopped. So now the concept of induced hypertension is not there. So safe, it can be a small amount of rise in BP is okay if it is a small unruptured aneurysm. So you can use norepinephrine versus phenylephrine depending on the cardiac status of the patient. Rather, now milrinone is coming up in a good way. It is used in patients with ventricular dysfunction. It improves cardiac output and cerebral blood flow, and it has been used in heart failure for so many years. So, endovascular rescue therapy, intraarterial verapamil, nicardipine, which is not available. Milrinone is available. Balloon angioplasty, obviously, with hemodynamic augmentation. But hemodynamic augmentation is not always indicated. So no proven benefit of RCTs. Probably they will need more robust prospective data because most of these trials had retrospective data. So coming here with a good study which has established the role of milrinone is the Montreal protocol or the Montreal hospital that I have highlighted, Montreal Neurological Hospital protocol. So what they did is that it is still reiterated both intraarterial and intravenous milrinone can be given. Okay. So the doses differ. You start with a bolus of 1 mics to 0.75 mics per kg per minute. Then you gradually reduce in aliquots of 0.25 mics per kg per minute with serial TCDs. Anti-inflammatory role is there of milrinone, and it is seen that it reverses the delayed cerebral ischemia. PCD and clinical examination needs to be done very frequently. And obviously, you anytime you feel that your mean velocities are rising, you have to again go up by 0.25 mics per kg per minute. So this is how we titrate. But there is this article which you can all go through. This is how it is done. It is a good article too, which has established the role of milrinone. Nowadays, we are using milrinone in IV as well as intraarterial. We are also giving. Seizures and status epilepticus. Obviously, seizures can happen. Non-convulsive status will worsen the DCI. Safari score is basically dependent on four factors. It depends on your age. It depends on presence of hydrocephalus, onset of the stroke, and the location. MCA territory is most associated with high convulsion risk. So a score of more than 5 is obviously a high risk. So there is no proven value of prophylaxis in such cases. But okay, if there is an early onset seizure, it can be given with short duration of therapy. Now, which therapy? Phenytoin can be used, but it has side effects, and also its pharmacological equivalent dose has to be calculated. Levera and perampanel, Levera is used very frequently, and so, but the studies are of doubtful significance. Next, we have the ICP. Monitoring is debatable. ICP monitoring in a case of subarachnoid hemorrhage is basically because of the cost that is involved. So, recommended in cases of GCS less than 8, neurological deterioration, acute hydrocephalus. So, gold standard, if you want to do an ICP monitoring, will be a ventricular catheter because it will help in CSF reduction also. It will be both therapeutic and diagnostic. So, which single study that has come up is this study, which is the Synapse ICU study, which has come up in ICP monitoring in cases of early acute brain injury, specifically in cases of subarachnoid hemorrhage. But what they have taken is that they have taken very sick patient, that is patient with GCS of as low as M5 and E1. So they said that in very sick patient, ICP guided therapy can be helpful, or rather, ICP guided intensive therapy can be helpful in severe cases because how do you titrate the cerebral perfusion pressure? It is MAP minus ICP. So, if you know the ICP, you can regulate your MAP accordingly in order to maintain a constant cerebral perfusion pressure. So, going back, lumbar drain again that I have already discussed. VP shunt, a lumbar drain, if the person has persistent hydrocephalus, needs to be converted to a VP shunt. So the factors that are there is IVH, high Fisher grade, old age, and all these things. Next important thing is that can we non-invasively measure the pressure in such cases? Yes, ONSD can be done, but still high quality trials are pending in ONSD, specifically in case of subarachnoid hemorrhage. So hyperventilation, obviously, it can be done. It is avoided in the initial 6 hours, that is the period of acute brain injury. Head elevation can be given, osmotherapy can be given. Hypothermia, also very limited evidence. There are few studies that have said that hypothermia can be instituted, but most of them have shown no mortality benefit. And rather, the complications were high. In particular study, there was a chance it increased the risk of further bleeding. Coagulopathy was documented. Decompressive craniectomy, obviously, in cases of infarct, it will improve the it will decrease the cerebral pressure in ICP, and will not probably there is questionable improvement in functional outcome. But it is said that early decompressive improves your lower limb disability according to modified ranking score. Coming to the PBTO2, PBTO2 is again a very good tool that you can do if you have the resources. It is brain oxygenation optimization. So the goal that was done in the study came in 2019, is a protocolized brain oxygenation. They said that what is the end point of measuring cerebral perfusion pressure? The end point of measuring cerebral perfusion pressure is your cerebral oxygenation. So cerebral oxygenation can be improved not only by increasing the blood pressure, you have to correct the anemia, you have to correct the oxygen delivery to your target organ. So if you can measure the PbTO2, it has come up in traumatic brain injury also. There is this boost trial, and it is now coming up in subarachnoid hemorrhage also, which is said that if there is a staircase therapy, start with 20, raise the PbTO2 by 2 to 3 or 2 to 4 millimeter of mercury, and it has led to definitive improvement in disability. But further trials are needed if you want to show any mortality or long-term benefit. So again, this another 2024 diagnosis and management of subarachnoid hemorrhage. This trial that has come up. So here it summarizes on one picture. It summarizes the entire scenario. So airway breathing on the right side, secure GCS, all these things, high oxygenation, avoid hyperoxia, PSCO2, prevent rebleed. But then again, this BP target should not be followed. Rather, a tailor-made therapy that I have told you. Correct coagulopathy. Avoid raised ICP, GCS monitoring, pupils monitoring, treat seizures, hypertonic saline, mannitol. If measures fall, then you can go for urgent EBD. And initial resuscitation is hemoglobin more than 8, euvolumia. Initially, it was triple H therapy. Now it came down to single H therapy, but still augmented hypertension is now out. It is normotension now. So it is either euvolumia and normotension. Correct electrolyte and monitor ECG. Nimodipine obviously has to be given. Neuromonitoring, you see regular bedside assessment, ICP, CT angio DSA, PCD or TCCD, EEG, continuous EEG, PbTO2. PbTO2 can be, it is a useful tool now. And associated, we can do cerebral microdialysis, but then again, it is basically to see the lactate pyruvate ratio, but which is purely a research tool. It is not possible in clinical scenario. Prevent DCI, maintain normovolumia, maintain normoglycemia, maintain normothermia, maintain normonatremia. Simple as that. All normal, no role of H now. General medical support, pharmacology, DVT prophylaxis, aggressive anemia, tight glucose control, but then again it is controversial, tight glucose control. So maintaining it to be around about 180, 200 is now still acceptable. Correction of electrolytes is there, obviously. ICP, avoid hypoxia, hypercarbia, prevent hypotension, adequate analgesia, prevent high pressures, ventilatory pressures. Still, it is said that in sometimes in cases of neurogenic pulmonary edema, you can raise your PEEP levels, but some a PEEP more than 10 centimeter of water does not hit your brain or cause too much of rise in ICP. But still, this particular uh, number of 10 PEEP is controversial. So you have to take other factors into account also. Avoid neck torsion, compression, avoid head down position, maintain normovolumia, treat fever and seizures. Cardiopulmonary support, avoid sympathetic overstimulation, then maintain oxygenation, cardiac enzymes. Again, another entity that needs to be, I will come a little bit later, is the stunned myocardium, neurogenic stunned myocardium and neurogenic pulmonary edema. These are the two entities that needs to be. Hemodynamic augmentation can be given, but just that it has to be within 20% of the baseline. Urgent endovascular therapy if no, obviously improvement is there. So cardiac complications, coming to the cardiac that you may face, it can be conduction abnormalities, myocardial dysfunction. Now the typical picture that we have is stunned myocardium because of sympathetic hyperactivity. How to differentiate it from your standard MI is that the territory which is affected in a neurogenic stunned myocardium will not correlate with the vascular territory. So obviously the area of ischemia will not correlate with the vascular territory. That is how you generally come to know about a neurogenic stunned myocardium, differentiating from an actual MI if it is happening to the patient. And Takotsubo cardiomyopathy is obviously again secondary to catecholamine release. It is mostly around in and around the apical ballooning in and around the apex. But it is a classical picture which may not be seen always. So apart from this, I have already discussed central fever. Yeah, this is an important entity. Central fever can happen. So you should know how to differentiate a central fever from a sepsis. So central fever can definitely be there in cases of raised ICP or a poor grade aneurysm. So there is a huge role of growth hormone and IGF-1 in the role of central fever. So there should be continuously temperature monitoring and there should be aggressive temperature treatment and obviously continuous search for source of sepsis. Hemodynamic considers stress cardiomyopathy, avoid hemodynamic instability and hypertensive peak before aneurysm treatment. Consider M for euvolemia, serial troponins, EEG, and echo. Sodium in electrolyte balance is very important here because most of the poor grade aneurysms land up with SIADH or CSW. You must be knowing how to differentiate between SIADH and CSW because the line of management is totally different. You have to restrict fluids in SIADH and in CSW, you have to, actually the patient is dehydrated, you have to give him fluids. Deep vein thrombosis, as already discussed. Respiratory scenarios like chest X-ray CT, obviously to rule out or differentiate between neurogenic pulmonary edema versus a ARDS or a VAP in such situation. So here you again can see that use protective mechanical ventilation. P-plat should be less than 27 and driving pressure should be less than 15. Titrate PEEP according to respiratory mechanics and oxygenation. So there is no single goal that has been given. Again, I will not go into details of it. It is basically how to, the idea should be how to differentiate between neurogenic, between VAP and neurogenic pulmonary edema. So metabolic and fluid things, so optimize CPP and oxygen delivery, adequate preload, euvolemia, adequate contractility. Cold directed therapy can be used invasive versus non-invasive. And obviously the electrolyte imbalance needs to be taken care of. Specifically, these two entities needs to be, is very common and these entities needs to be checked. Nutrition and glycemic control, enteral versus parenteral. uh, Adequacy, hyperglycemia worsen outcome. So target is 180 to 200, a little more intensive therapy that can be given. That the NICE guidelines have come up with less than 140, whereas the Neurocritical Care Society have come up with 180 to 200. So the idea is to maintain in around 180 so that there is not too intensive control or ultra intensive control versus ultra liberal control. So in nutrition is definitely needed. Coming with temperature control, obviously central fever must be kept in mind and the central fever must be adequately handled because the main cause, there are two main causes of central fever. One is blood in the ventricles and second is your imbalance between IGF-1 and growth hormone. Third is another thing is ongoing electrical cortical spreading depolarization in the hypothalamus or the in and around the brainstem. So this temperature control is very important here because most of us fail to understand whether and we treat the infection part, but acute brain injury generally presents with a central neurogenic fever. There is very good article. I'll share it in the group probably how to differentiate between central neurogenic fever versus sepsis or any other causes of fever. So development prophylaxis I already discussed before. It has to be after the aneurysm control, and definitely low molecular heparin can be added later. So with this, I'll be completing the aneurysmal subarachnoid hemorrhage management of the patient. Per se, the ICU part, mostly the recent trials have been included, but there are few review articles and good thing that can definitely be helpful. Anyways, thank you.
Thank you, student. Thank you, Saurabh. Student, if you have any question, query regarding the subarachnoid hemorrhage management or related to to acute stroke management, you can ask. We have a eminent speaker here, is expert on neurocritical care. So you can unmute and you can place your question.
So treatment of central fever.
Yes. Treatment of central fever. Okay, now first you have to understand the etiology of central fever. Okay, there are these etiologies that I told you. So central fever will respond to a variety of treatment. Okay, and a variety of drugs have been used, starting from alpha 2 agonists. Okay, clonidine has been used. Dexmedetomidine, there's analgesication with dexmedetomidine has also come up in a big way. Hormone replacements. Then there is even a role of that we of SSRIs and SNRIs. There are role of SSRIs and SNRIs that are also can be given. Then there is third thing is that in central fever it comes with non-convulsive status sometimes. So measuring the electrical activity of the brain and starting adequate antiepileptics can also be there. Role of gabapentin also is there in central fever, and even all GABAergic drugs and anti-glutamic agents can be given in central fever. So there has been several trials, but the one thing that needs to be stressed is that there is no particular drug of choice, as say, because central fever, if it is diagnosed, it is very difficult to diagnose because two things: blood in the ventricles. If you see, compare coiling versus clipping patients, what has happened is that in clipping patients, you generally do a craniotomy and you thoroughly flush the ventricles. So the blood in sometimes is removed. Whereas in cases of coiling, the blood remains. It generally goes away after some time by absorption or degradation of the hemoglobin. But this is also a cause of central fever. If blood can be drained, that then one trial, a Lumas trial, which came very early, they had put a drain to remove this blood, and then it was found the incidence of central or neurogenic fever was less in such patients. So it is multifactorial actually.
The role of bromocriptine in central fever, like
Yes, bromocriptine is there. Bromocriptine is a dopaminergic agonist. It is there, but it is still actually bromocriptine can be given when there is some involvement of the dopaminergic pathways. But sometimes what happens, the central fever is mostly in the blood, is in the posterior fossa, and in posterior circulation, bromocriptine role has been a little bit controversial.
sir, that near infrared spectroscopy for non-invasive intracranial pressure monitoring. Can you just
Yes,
tell
yes.
me a few words about this thing?
Okay, near infra NIRS. NIRS is
Yes, sir.
basically a cerebral oxygenation module. Okay. But it can be indirectly used to measure. You wanted NIRS to measure ICP.
Yes, sir. Yes, sir.
Yes, yes. There are few role of NIRS which correlates with ICP. We can definitely the normal value of NIRS is 60 to 80. Okay. So it is seen that in raised features where this patient is raised ICP, specifically in early brain injury, there is decreased oxygenation. The decreased oxygenation is generally, you must remember one thing: NIRS is a hemispheric monitor. It is not a global cerebral oxygenation. So it has to be interpreted in association with other monitor. Okay. So you just cannot diagnose an ICP, raised ICP on NIRS per se alone. You have to measure it with either ONSD or a invasive ICP. But what studies have shown in neuromonitoring is that near infrared spectroscopy, in cases of acute brain injury where there is brain edema, there is definite decrease in oxygenation of the brain. So it has to be correlated with your ONSD monitoring, or if you want to do an ICT monitoring.
Sir, one more. Clipping versus coiling. Like as
Yes.
you have told, there's a data which is not proven that which is good, like sufficient data is not available for clipping versus coiling. Because coiling is done by interventional radiologist and clipping is done by neurosurgeons. So mostly neurosurgeons prefer the clipping and interventional radiologists are preferring coiling. Which is better and how to decide which patient should go for clipping or coiling?
So this is a trial that you have given me. This is a long question. So first of all, you and me won't decide the clipping and coiling part. So there are multifactorial. If you say patient-related concern, disease-related concern, financial concern, all these things come up while deciding between clipping and cocktail. So it is an academic session. I'll just discuss the patient related concerns and the disease related or the surgeon driven, the procedure related concerns. Now, whenever you are seeing you have heard about ISAT trial, ISAT 1, ISAT 2, ISAT 3. So what actually happens is that you have to know what grade your aneurysm is. According to experience, or rather according to established data, what the evidence is that if it is a good grade versus a poor grade. Now, a poor grade aneurysm will have blood, a lot of blood in the ventricles. Okay. So it will be a thick SH with IVH. So in such situation, it is better if it is better to do a clipping. Why? Number one. Number one is it is better to do clipping because you can flush or drain the blood from the ventricles. Number one. Number two, it is a poor grade aneurysm. So there will be definite significant amount of vasospasm and propensity for DCI. So vascular control needs to be taken. Third, what type of aneurysm it is? It is a giant aneurysm. Is it there is something called as neck to dome ratio. If the neck is long, it can be easily clipped. But if there is neck to dome ratio is poor, if the neck is short, it becomes difficult to clip. So the anatomy of the aneurysm, okay, the location of the aneurysm. Per se, MCA aneurysms are difficult to approach by clip, so it is easily coiled. Posterior circulation, it is difficult to approach by clip, is easily coiled. So again, the location of the aneurysm. So all these things, these type of patients will generally prefer the clipping because the surgeon and will generally say that I can clip any aneurysm. It is true. Anybody can clip any aneurysm, anybody can coil any aneurysm, but there are certain things, these things have to be taken care of in order for a better outcome of the patient. Similarly, when I come to coiling, you have to find out anterior circulation or aneurysms, posterior circulation aneurysms, coiling. Suppose there is a bilobed aneurysm. Suppose there is a short neck aneurysm. Suppose the neck is a little bit actually rotated in such situations. So here the coiling will come to your action. So what the yes. So actually what the trial had said is that posterior circulation aneurysms are very easily coilable. Anterior circulation aneurysms are also coilable, but if it is a poor grade, if there is a dome to neck ratio less than 0.4, if it is a difficult anatomy, and if it is in such cases, you can go for coiling. What coiling benefit does it give you? It gives you a less morbidity, the morbidity of the surgery. Next, new onset cerebral infarcts are less unless and until it is a non-targeted coiling. And third thing is that overall disability improvement was there, but there has been no mortality benefit. If there was a mortality benefit, then everybody would have coiled the news.
Sepsis, central fever.
Yes,
There,
yes,
there was one
yes,
article.
yes, yes. See, central fever versus septic fever. Ah, I've already told you in the first question was that only. So in the both are SIRS. So SIRS markers will be there, but it is very simple. In a sepsis, you will find a septic focus. And in SIRS, you will probably not find a septic focus. Another very important thing that I want to tell you is this. If you have all procalcitonin you are sending in sepsis, okay. So what I'll tell you is that procalcitonin may be fallaciously high in cases of central fever because of the SIRS response. So this is again a fallacy. So you cannot go ahead with just procalcitonin. You have to see other markers also. Third thing is that central fever versus sepsis, generally you will serial values of your counts and all these things you will find out. In central fever, there will be no change in that. Your antibiotics will not respond. And there are also other differences, specifically your hormone. The other thing that there is issue is that you generally tend to have a hormonal profile disbalance in a central fever. So whether in septic it can have or you may not have. So I'll generally suggest you that you go through that article which I wanted to share about central fever versus other types of fever. So you will get your answer there mostly.